I think now we can get started. Good morning or good afternoon, everyone, depending on from where you are joining us. Welcome to the third session of the Knowledge Exchange webinar series, Bridging Health Systems. This session will focus on the inclusion of the informal workers, organized by the Egypt Impact Lab at JPAL MENA in collaboration with the Universal Health Insurance Authority and the World Health Organization in Egypt. Before we begin, I would like to inform you with a few housekeeping notes. First of all, please note that this webinar is being recorded and the recording will be shared with the participants after the event. Also, this webinar is being held in English with live interpretation available in Arabic. You can select your preferred language from the interpretation icon on our Zoom toolbar. Also, the session will run approximately for 90 minutes, and please feel free to drop your questions in the chat box throughout this, and we will address them during the open discussion. Also, for our esteemed panelists, if you wish to share a PowerPoint presentation during your talk, please use the share button on the Zoom toolbar. And please, once you have finished presenting, kindly stop sharing your screen to allow the next speaker to do so if needed. Now, I'm delighted to hand it over to Dr. Reham Rizk, the director of the Egypt Impact Lab, who will be delivering her opening remarks. Dr. Reham, over to you.
Thank you, Arwa. Good morning, everyone, and welcome to the third session of the Knowledge Exchange webinar series, Bridging Health Systems. It is a pleasure to see so many colleagues and partners joining us once again. On behalf of the Egypt Impact Lab and JPAL MENA, I would like to thank the Universal Health Insurance Authority and the World Health Organization in Egypt for co-hosting this series with us. Also, I would like to extend special appreciation to our colleagues from the JPAL Southeast Asia office, Mrs. Lina Marliani, the Executive Director, and Ms. Lisna, Policy and Training Manager, for their continued support and collaboration in making this session possible. The Egypt Impact Lab, briefly, I'm gonna go with you through who we are and why this series exists. The Egypt Impact Lab, it's a government-embedded lab, housed and institutionalized within the National Institute for Governance and Sustainable Development. The lab mission is to strengthen the use of evidence in policymaking by connecting rigorous research with national priorities and by building government capacity to design, test, and scale effective solutions. The Knowledge Exchange webinar series is a part of that mission. It creates a space for government-to-government peer learning, bringing together policymakers, technical experts, and researchers to discuss what works, what does not, and what can be adapted to Egypt Universal Health Insurance. Our first session, held earlier this year, focused on the foundation of the universal health coverage and experiences from Chile's health system reform journey, featured His Excellency Dr. Emilio Santelices, the former Minister of Health of Chile, as our guest speaker. This session was organized in collaboration with JPAL, Latin America and the Caribbean, allowing for a rich exchange of lessons on institutional reform and equity in healthcare access. Our second session, held in July, explored benefit package design and the role of the health technology assessment in informing universal health coverage implementation. The session featured our colleagues from the Health Intervention and Technology Assessment Program, HITAP, in Thailand, and was organized in collaboration again with JPAL Southeast Asia, highlighting how evidence and prioritization frameworks can support equitable and cost-effective health coverage. Today, we turn to a very crucial issue that directly impacts the success and the sustainability of the Egypt Universal Health Coverage ambitions, the inclusion of informal workers and health insurance. Honestly, this topic could not be more timely. Informal workers make up almost 60% of the Egypt labor force. Many of them, especially located in rural and low-income areas, have no social or health insurance coverage, leaving households exposed to financial shocks. In fact, out-pocket health spending still accounts for over 60% of the total health expenditure, which is one of the highest in the MENA region, while public health spending remains only 1.7% of GDP. These realities underline why Egypt's universal health insurance system and our joint learning efforts are so important. Through the universal health system, Egypt is making a historic shift toward a unified, equitable, and financially sustainable health system. Yet, as we all know, achieving universality depends on our ability to reach and include informal workers who are currently outside the system. Today's webinar draws on Indonesia's experience in tackling this challenge, a country that faced similar issues of scale, informality, and affordability. We will explore what Egypt can learn from Indonesia's strategies, including now administrative support, targeted subsidies, and effective outreach helped expand the coverage. We are honored to be joined by distinguished speakers who bring deep policy and research perspectives to this discussion. Dr. Mahlil, the Director of Planning and Development at the BPJS, Kutzin, Indonesia's National Health Insurance Agency. Dr. Joe Kutzin, the Senior Advisor on Health Financing at the World Health Organization. Dr. Sumarto, the Senior Research Fellow at SMERU Research Institute in Indonesia. And finally, Dr. Ahmed Seyam, the Deputy CEO for Technical Affairs at the Universal Health Insurance Authority in Egypt. Each of them brings a unique lens from program implementation to international and local expertise and research lens as well. This will help us think collectively how to strengthen the Egypt health reform pathway. It's my pleasure now to hand it over to Dr. Ahmed Khalifa, the health economist at the WHO Egypt, who will moderate today's discussion, and we look forward to an engaging and insightful conversation under his guidance. Thank you all once again for joining, and we hope today's exchange inspires actionable ideas to ensure that Egypt's universal health insurance system truly leaves no one behind. Thank you very much. Over to you, Dr. Ahmed.
Well, thank you very much, Dr. Reham. It's always a pleasure, to work with you and with the JPAL team, of course. And good morning, everyone. I'm very glad to welcome you all to the webinar series and also to this very important session on today's webinar, which is on inclusion of informal workers into the universal health coverage systems. And as we all know, the challenge of inclusion of informal workers, which always been called the missing middle problem, which we can hear, of course, on that during the presentations. It remains one of the key barriers to achieving universal health insurance everywhere in the world, with all income levels. And we cannot, as Dr. Reham mentioned, claim that we're making progress on universal health coverage without making sure that those people in the informal sector are effectively covered. I think from being in the country office that Egypt is taking this issue seriously. And I would like to highlight on something that was very recent, that the government had a recent publication called Egypt's Narrative for Economic Development, Reforms for Growth, Jobs, and Resilience. This is one of the key documents to lay out the roadmap for Egypt's next couple of years it's a government document that was led by not Ministry of Health, but Ministry of Economic Development and Planning. But what caught my attention in this document is that in one of the action points, it says that, and I quote, by June 2026, Egypt will strengthen the universal health insurance system through the development of a strategy to expand access to the underprivileged groups. Maybe this is another topic, but what's important is that it entails a comprehensive review of the universal health insurance coverage for informal workers, including those above the nationally defined poverty threshold, with a focus on their current enrollment levels and associated financing mechanisms. And this by June 2026, which means that the strategy should be prepared in 6 or 7 months from now. So this is just to highlight that it's a government, yes, it's a global issue, but it's also a government priority, and also it's a very timely topic. So in the next hour or so, we will, as Dr. Reham mentioned, we will hear 4 different perspectives on the topic from 4 distinguished panelists, as just introduced by Dr. Reham, and I will give the floor to each panelist to introduce himself, in details at the beginning of his talk. So we'll hear first from Dr. Joe Kutzin, the global overview of this challenge to lay the foundation for our discussion. We used to have this dynamic in our series. In the first series, we heard from our current health financing unit head, Matt Joe, on the global perspective on benefit package, and this was followed then by His Excellency Dr. Santelises on Chile's experience, and from Dr. Ahmed Seyam on Egypt experience. So we're kind of replicating the same approach. We'll start by Dr. Joe to give us a global overview on this challenge to lay the foundation for our discussion. And this will be followed by a short intervention by Dr. Ahmed Seyam, who will reflect on Egypt's current context. After this, our 2 distinguished panelists from Indonesia, Dr. Sudarno, with the research perspective that he brings to the discussion, and Dr. Mahlil Ruby, with the policy implementation and government perspective, and also insights from the JKN experience and how this can give valuable lessons to Egypt's journey towards universal health coverage. So we're planning to have all of this in 1 hour, which means 10 to 15 minutes per each participant. But I will give the floor first to Dr. Joe Kutzin. And as many of you know, Dr. Joe has been with WHO. He's currently not with WHO, he's retired, but he has been there for, if I know correctly, more than 30 years. And he has been leading the health financing work during this time. And many of you know that he's the one behind conceptualizing many of the work we're doing now on health financing functions and the issue that we're discussing today. So Joe, we're very pleased to have you, and the floor is yours now.
Thank you, Ahmed, for that kind introduction, and also the introductions and overviews from Dr. Arwa and Reham from the Impact Lab, if I understood it. And I will, so as not to take any more time, just to, hoping this is visible to everyone now, right? Let me see. It's in the process of sharing.
It's
Great.
in
So I'm going to...
process.
It's okay?
No,
It's
still not.
It's in the process. Yes,
Yes.
it's not visible.
Okay, so perhaps there's a bit of a lag. So I'm going to try, as was said, to give a bit of a short overview of some of the issues and challenges, but also based on the introduction I was hearing, to try and think a little bit about what might be some key areas around the whole research to policy agenda around some of these points. So just to start, and as just to give you an overview of what I wanted to do, to go over kind of the core concepts, especially around, again, operationalizing universal coverage, and what we mean, what are the specific issues of informality and how those intersect with health financing. Okay. So just now to go into that, the main thing we talk about, and a lot of times the political discussion around UHC is very much about the idea of achieving it. But I think more practically, we can talk about improvement. What to be done in the next few years to both reduce the unmet need for quality services and reduce financial hardship across the population as a whole. And I think this is critical when we're talking about today's agenda, that we're not just talking about those who are already in the scheme, such as the universal health insurance, but across the entire population. And so we're looking at reforms that not only make progress on those objectives, but also strengthen the kind of institutional foundations to take this forward in the future. And it may be in the near term, one moves more on this ladder about ensuring that we have the foundations in place rather than just making progress on the objectives. In terms of the informal sector, informal workers, the really critical issue from a health financing perspective is to think about people who are outside of regular salaried employment, because, as you know, the point is that that makes them difficult to tax directly. And direct taxes in this sense are taxes levied on individuals or firms as compared to indirect taxes, which might be levied on consumption, such as VAT or trade taxes like tariffs. Okay. In reality, we know that there's a lot of diversity within this expression, informal workers, many poor people, some not poor people, self-employed, professionals as well. I think the critical thing, though, again, is that difficulty administratively to capture them for tax purposes and so on. And in general, for UHC, we're also talking about anybody, whether they're seeking work or not economically active, we still want to be including them in coverage. Basically, there are two broad approaches that countries have taken for this. One, as in Egypt, is to go for this contributory-based entitlement. And what we know is that unless there's a mechanism that actually is meant to incorporate and fund people who don't contribute or are hard to make contribute, you have what is a de facto voluntary insurance, even if it is legally mandatory. And the ability to cope with this really depends on the relative size of people outside of regular formal employment. And then other countries have taken a non-contributory base, so entitlement based on citizenship or residence. This also has a lot of requirements to make it work. Nothing is easy just by the label that it uses. But given the law, we're going to focus today on the issues and options with contributory-based approaches. Maybe using the term, sometimes we use the term social health insurance, again, which is referring to any type of mandatory contributory arrangement in which the entitlement to services derives from the contribution that either a person makes or that is made on their behalf. And so it can include general revenue transfers to support the overall system, which happens in some countries, or just for non-contributors in particular. Now, what we know in practice is that, again, voluntary prepayment doesn't work. And this comes down to two things, really. The economics of health insurance and the issue of adverse selection. So people, younger and healthier people would tend not to join, leaving the pool with older and sicker people, but also a tax collection issue, right? So if our tax systems were very effective at both targeting and collecting income taxes, we wouldn't really have this problem. And again, simply stating or declaring contributions mandatory doesn't change that in any way. So again, the direct taxation is a challenge, and we have this de facto voluntary contribution of people outside of this. One of the issues that I think each country needs to consider, and this is something that should be looked at, is whether, in a sense, a failure of tax collection and dealing with that should be the job of the health agency, right, or the tax authorities. And certainly I believe that when you're looking at issues of efficiency across the whole of government, that you want to have the agencies that have specialized skills in collecting taxes to take care of that, while the health agency focuses on what it should be doing, which has less to do with revenues than collecting revenues than with spending. Now, what we see in practice. These are data from the WHO's Global Health Expenditure database for the handful of countries for which we have some data on self-employed persons, which is kind of a proxy for the informal sector, self-employed persons' contributions to social health insurance as a share of the total revenues of social health insurance. And while the data are missing for a lot of countries, for those countries where there are data, you can see most of them are under 5% or less than 5%. And really only, as it shows here, only the Philippines seems to do well, Poland to some extent. But for the most part, you won't expect to get very much of your overall revenues from individual contributions. Now, other issues around challenges of informality for sustaining both revenue collection and affiliation is that there are costs. There are costs to tracking an individual's contribution status. So there has to be the administrative capacity to identify different groups that are going to be funded from the budget to the extent that you're going to subsidize at least some of the populations. And it does require strong systems and administrative effort. So that's one aspect that you would have in any situation. But in particular, and this is something where there has been some research done in some countries, and this could be an area of research in Egypt, to understand the nature of informality. This chart reflects data from, I think, 8 Latin American countries from some time ago, and it makes the point that basically you're not born informal and die informal or vice versa, that people move and transit, as they say, between formal and informal status, which is in the blue bars for these countries, the share of the population in any one year where a worker changed their status from formal to informal, and in red for those who changed their status from informal to formal. So what it means is that if you're tying coverage to contribution and you're getting contributions basically from the formal, that you have to really invest in tracking this in and out. It's expensive. And to the extent that somebody loses their coverage because they lose their job, that has a whole range of other consequences. And one study from Mexico showed a loss of employment-linked coverage affecting the continuity of care for type 2 diabetes and having worse health outcomes as a consequence. So these are just amongst the challenges that have to be faced. And so this aspect of how big a problem this is in Egypt or how big a challenge, I don't know, but that's part of what your research could tell you. So just briefly to summarize how certain countries have responded, what seems to have worked, what remains a challenge. To some extent, and this is what has happened in higher income countries, finding a way to at least soften the linkage between entitlement and contribution through the use of general revenues. So you see here a few examples where in Japan, for example, about a quarter of all of the health insurance revenues come from general revenue transfers. In Hungary, this has shifted over about a 15-year period from being mainly contribution-based to being mainly non-wage linked contributions in terms of the overall funding. And France as well has diversified its revenue sources for health coverage from mostly wage-based contributions and now really a mix of sources. So, and the idea on the pooling side is that the contributions remain, but these are pooled with general revenues to provide this common benefit. For lower and lower middle income countries, or middle income countries now, I think with China, it's really China and Rwanda that have achieved high affiliation on a contributory basis. And here I just want to highlight what seems to have made this work so you could have an idea of what might be relevant in terms of possible adaptation to the context of Egypt. One is that not only do they use budget subsidies to support affiliation, but they use it in a very targeted way. And in China in particular, substantial budget revenues so that for any individual, the deal with them is essentially that if you pay 20%, we will pay 80% as the government. So that is part of it, that you use still a substantial amount of budget revenues. So it's not the case that, this enables you to reduce general revenue commitments. It does mean, though, that if you do this well, you can possibly get some additional revenues through the contributions. From an administrative perspective, and I think this is something that needs to be thought about, what has made this work better in these countries, whereas in other countries it hasn't worked very well, has been engaging local government officials. In other settings, you'd have to think of whether this could be local NGOs or how one would do it. But the message is that leaving it between a central fund and individuals doesn't seem to work, even with subsidies. So in the case of each of these two countries, the central government gives very strong incentives to local government officials to say part of your accountability. Let's say in Rwanda, the district mayors are accountable for getting their population enrolled into the program. And they get some bonuses if they achieve high levels of coverage. In China as well, there's a very strong pressure put on local government officials. Now, depending on your type of government, as I said, whether this is something the central level can, in a way, instruct or incentivize local government officials to do, or whether you use NGOs or however one might do it, that depends critically. And these two countries, what they have in common from a political perspective is very strong central governments with the ability to tell local governments what they can do. But the point is still that even with these mechanisms, you're not going to really get away from using general revenues, general budget revenues, even if you're using contribution, but to think about how you would do that in the case of Egypt through incentives, not only to individuals, but also to subnational entities, whether those are government or non-government. Okay, to summarize these messages, and what seems to be the case, although again, you'd have to look at how this would play out in Egypt. Certain countries have made some small gains, and I think we'll hear some from Indonesia, by essentially making it easier for people. So in a way to both ease the administrative process for people to affiliate, but also especially to renew. And in Indonesia, which I think we'll hear about, Ghana as well, have used mobile technology to reduce the administrative headache, the paperwork requirements essentially for people to do it. They haven't had major gains, but it's still worth doing if the gains in affiliation and revenues outweigh the costs of administering the system. The other message, again, which I think is important in the case of Egypt and really every country, is how to work across government to streamline administrative processes for enrollment and re-enrollment. So, for example, is it possible to use information from the tax authorities that are used to license self-employed professionals so that you can follow up on their contributions? If the tax system uses employment-based withholding tax for personal income tax, connect that with whatever's being done for social contributions rather than running parallel systems. To the extent that you already have mechanisms for targeted social assistance, health shouldn't develop its own in parallel, but use existing mechanisms and then link, ideally with something like a national ID number to link across government systems. So I just wanted to put those kinds of ideas of administrating, smoothing or simplifying administrative processes and working across government to try to make it easier for people. So to summarize everything, it's never going to be easy. If it was easier, tax authorities would already be doing a good job of collecting income tax from people in the informal economy. So don't expect a lot of revenues from that source. It is possible to get high levels of coverage even with a contributory system if there's a large injection of general revenues. We don't want your health insurance agency to be overly distracted with revenue collection. Try and leave that to the existing agencies, whether that's an existing social insurance agency or ideally the national tax authorities, and let the health insurance agency focus on purchasing. But it is possible to get some gains by easing administrative processes and working across government in a very smart way. So with that, I'll stop and hope that was helpful for you.
Yes, that was very helpful, especially the three takeaways that I took, like the roles between the central government and local government. Local government, in case of Egypt, would be probably the role of the governors, the governorates, responsibility or accountability towards the implementation. Probably also the role of the head of directorates, heads of branches. I'll leave this to, of course, Egypt speaker. Also, the integration across different databases and different institutions, as well as the division of labor between the tax authority and the health insurance authority, the last point you mentioned, and to let the health insurance authority focus more on purchasing. Now, with that, I will move to Dr. Ahmed Seyam, Deputy CEO for Technical Affairs in the Universal Health Insurance. And I would like to ask you, Dr. Ahmed, to give us a brief like situation analysis on the specific issue of the informal sector inclusion. What are the challenges, if there are challenges, in enrolling those informal non-poor workers? To try to give us some numbers if this is readily available, and if not, so what are the information gaps that you're working on in order to address reaching this group? So the floor is yours, Dr. Ahmed, and if you please open your camera, that it will get into the screen, and if you want to share some slides, it's of course up to you.
Definitely. First of all, good morning, and thank you, Ahmed, for the presentation. Of course, thanks to Dr. Joe for the very insightful presentation. And I also want to thank all our dear panelists, so I'm very much looking forward to hearing from all of them. I'll try to keep my intervention quite brief. I'll just give just a general understanding on the universal health insurance, just to give some context. And I will also be sharing some insights from the study that we did on the informal sector citizens in Port Said. Just give me 1 second to share my screen. Okay, so hopefully you can see my screen clearly.
Yes.
Okay, so just to start with the country context, of course, Egypt is a very big country. We have a population that's currently exceeding 108 million people. We have a GDP per capita that's approximately 3.5 thousand US dollars per capita, which makes us a lower middle income country. Out of our GDP, the public health expenditure only represents around 4.75%, which is only 1/3 of the total current health expenditures in Egypt, while of course out-of-pocket payments is the major source of financing, and it's approximately 59% as per the last published national health accounts. Of course, Egypt is committed to the SDG agenda and achieving universal health coverage. And consequently, of course, as of 2018, the Egyptian healthcare sector has been witnessing major reforms. This is how the health system in Egypt used to look. Well, and actually, this is a diagram that's borrowed from Ahmed Khalifa, so thank you for that. It just elaborates the complexity in the Egyptian healthcare system, where we have multiple financing agents and multiple providers, and actually multiple schemes that are running in parallel. So that's why we started thinking of implementing a universal health coverage scheme, which is the universal health insurance. And this is just a very brief comparison between both systems. So we're moving from a system that provided incomplete coverage to specific population groups, and mainly public and formal sector employees and preschool and school children, and with some widowers and a very limited number of women in female-headed households. While the UHIS promises universal health coverage for the entire population. In the old system, we had multiple fragmented fund pools, while in the universal health insurance, we have a single fund pool that is managed by the UHIA. In the old systems, the coverage was mainly individual-based coverage. So as a formal employee, for example, myself, as a formal employee, I'm covered under the health insurance organization. But for example, my wife, if she does not work, then she doesn't enjoy the coverage that I enjoy, as well as my children, if they're past the school age and they move to university, for example, then they're also not covered under the health insurance. While, of course, in the universal health insurance scheme, it's a family-based coverage scheme. So each head of household is expected to pay the contributions on behalf of himself and his entire household. The old system also offered optional enrollment and an option to opt out of the scheme, while in the universal health insurance is compulsory enrollment with no opt-out option. The old system also had a provider-payer sort of integration. So the old health insurance organization, the HIO, functioned in more of a HMO model. So they collected the fund and they were managing the financing, and they also owned and operated multiple hospitals and polyclinics, in addition, of course, to contracting with other providers, which were mainly from the public sector. In the UHIS, there's a purchaser-provider split where the Universal Health Insurance Authority is the financing agent or the payer, and we contract with different providers from the public or the private sector. In the old system, also beneficiaries were allocated to certain providers, mainly, as I said, HIO facilities, while in the UHIS, beneficiaries have free choice between providers. The old system also mainly functioned on a line item budgeting basis, but in the universal health insurance, we adopt output-based payments with our providers. And of course, in terms of the benefit package, the old HIO did not have actually a defined benefit package, whereas in the universal health insurance, there is an explicit benefit package that is covered under the universal health insurance scheme. And this is a representation of how the healthcare system hopefully would be after the completion of the universal health insurance scheme. So as you see, the UHIA is the main payer responsible for collecting the revenues and purchasing from different providers in the public or the private sector, while the Ministry of Health will retain its function as a purchaser for public health services and preventive services and other services that are not covered under the Universal Health Insurance Scheme. And this is a layout of the different government entities that are involved in the process. And as we can see, the UHIA is in the red box on the left, which is responsible for financing and strategic purchasing. So we collect contributions from the citizens, and we collect other revenue sources from the Ministry of Finance, whether earmarked taxation or subsidies that are paid by the Ministry of Finance on behalf of the poor and vulnerable populations. And of course, we contract with multiple providers, which are highlighted on the right in the purple box, whether from the public sector or from the private sector. And our beneficiaries can directly receive services from any contracted provider, and then a claim, of course, will be submitted to the UHIA for review and reimbursement. Also, the Universal Health Insurance Law established GAHAR, which is the national accrediting body, and it is more or less the gateway to contracting with the UHIA. So the UHIA is not allowed by law to contract with any provider that doesn't have GAHAR accreditation. And we also have the UPA, which is the Unified Procurement Authority, which is responsible for procurement of various input factors for the providers. And we actually, at the UHIE, we work hand in hand with the UPA in all of the functions that are related to HTA, and also in terms of negotiation with manufacturers for setting the prices for drugs, consumables, devices, etc. And then, of course, at the top, we can see the Egyptian Health Council, which is the regulator for healthcare practitioners, and the Egyptian Drug Authority, which is the regulatory body for health technologies, and of course, the Ministry of Health, which is the super regulator in the healthcare system, responsible for policy and coordination between the different government entities within the healthcare sector, in addition, of course, to being the purchaser for public health services, preventive health services, and reproductive health services as well. So about the UHIA, the Universal Health Insurance Authority, it's a public authority that is responsible for managing and financing the Universal Health Insurance Scheme, aiming, of course, to extend our coverage to the entire Egyptian population, hopefully by 2032. So we're mainly responsible for revenue collection and pooling, as well as purchasing functions, which include, of course, the benefit package design, the costing, the pricing of the healthcare services, defining the provider payment mechanisms, and of course, the entire contracting process with the providers, as well as managing the claims that are received from the providers for the services rendered to our beneficiaries. And also the UHIA is responsible for developing and managing the IT ecosystem, the payer system, and health information exchange layer that more or less integrates the UHIA with all relevant entities, whether on the collection side and identification of the population, or also with the providers for providing their services and submitting their requests and claims. As for the revenue sources for the Universal Health Insurance Authority, so we have multiple, of course, revenues. We have the premiums, of course, that are paid by the beneficiaries, and some very minor co-payments for specific services that is also capped, and patients with chronic diseases and cancers are exempt from paying these co-payments. Of course, another component is the earmarked taxation and fees. So there's something called a corporate social solidarity contribution, which is levied on the total revenue of any economic entity in Egypt. We have earmarked taxation on cigarettes and tobacco products. We have some fees that are imposed on toll stations in highways, and on the issuance and renewal of driving licenses and motor vehicle licenses as well. And of course, there's also a subsidy that is paid by the Ministry of Finance on behalf of the poor and vulnerable populations that are identified by the UHIA and the Standing Committee for the Vulnerability Assessment. And also another part of our revenue is actually investing our surpluses over the years in order to create reserves to help us with managing the sustainability of the scheme in the future. So where we currently stand, we currently finalized phase 1, which includes 6 governorates, where we started with Port Said, followed by Luxor, then Ismailia, then South Sinai, then Suez, then Aswan. We currently cover 5.1 million beneficiaries. Our average enrollment rates across these 6 governorates are about 80%. Of course, some of the newer governorates we have lower enrollment rates than mature governorates such as Port Said, for example. And our provider network currently has 509 contracted providers, out of which approximately 25% of these providers are from the private sector. This is in terms of number of providers, but also in terms of the value of the claims from these providers is currently ranging about 15 to 18% of the total claims received by the UHIA. Now I'll be sharing some insights from the qualitative study that we conducted in collaboration with the ILO and a consultancy here in Egypt on the perception and the satisfaction and affordability of the universal health insurance among the informal workers in Port Said. So the study actually comprised of 24 focus group discussions that had about 139 participants. We developed two separate guidelines, one for people in the informal economy who are already enrolled and utilizing services within the universal health insurance, and another set of guidelines for non-beneficiaries in the informal sector who are potential targets for inclusion in the universal health insurance. Of course, we collected data on background characteristics of the participants, their perception of their health status and the utilization of services. And of course, for the beneficiaries, we collected insights on their experience with the UHIS and their satisfaction with the services that are provided. And for non-beneficiaries, we collected information regarding the awareness about the universal health insurance and their willingness to join the universal health insurance, and also the amount that they are willing to pay to enroll in the UHIS. And then we also collect information on the challenges the participants face to utilize healthcare services and their, of course, household expenditure and income. So I will go directly to some of the findings. So we'll start with findings for the cohort of the enrolled participants. So participants who were enrolled in the UHIS generally demonstrated a high level of awareness about the enrollment process, where they however, they also identified that there's a significant knowledge gap in relation to how the premiums are being calculated and the frequency of premium payments. So many of the beneficiaries didn't actually know that we have a flexible scheme for paying their premiums. It doesn't have to be actually monthly, and we'll come to that a little in the coming slides. And also, one of their primary issues also was the accumulated overdue payments from the date that their governorate was formally enrolled in the universal health insurance scheme. And this was also cited as one of the big factors that are behind their inability to continue utilizing the universal health insurance, because some of them had large amounts of overdue payments and they were a little bit burdened with paying the installments as per the reconciliation plan. Also, in terms of the satisfaction with the services, the beneficiaries raised several concerns mainly on their experience with the services that are provided. So there were some concerns related to the hotline, also some concerns related to delayed scheduling of their consultations and visits, and their referral for services, especially for services that are not available within their governorate. And also some of them were dissatisfied with the requirement to use debit or credit cards for payments, either in terms of co-payments or in paying their contributions as well.
Dr. Ahmed, if I just can intervene, can you please just try to summarize the results in the interest of time, so that we can just give
for sure.
It's very important, of course, study that we wanted to know more about. But if you can just highlight the key, yeah.
Definitely. So maybe we can skip some of the findings for the non-enrolled beneficiaries. They're mainly their inability to access healthcare services, and of course, with resulting in avoiding seeking medical care or delaying their treatments due to their high costs. And also, they had lots of doubts about the value of the system and the reason for paying contributions when they're not actually receiving services. In terms of the recommendations, one of the main recommendations was, of course, to raise the awareness among the beneficiaries, and this is actually an area where we are very active in at the UHIA, and we are launching multiple campaigns in collaboration with developmental partners and with local partners as well, and even partners within the government and the local governments within the governorates. Another recommendation was also to ensure that people are offered partial subsidized insurance. And of course, in that part, we have a little bit of limitation because we are bound by the legislation, which doesn't actually offer this. But through partnerships with multiple NGOs, we managed to sign multiple MOUs in order to have NGOs covering some of the overdue payments for some of the beneficiaries, or partially covering the contributions for people who are near poor and do not quite fit the requirements for subsidization by the Ministry of Finance. Also, another recommendation was implementing a debt relief or reconciliation program, and also this was something that the UHIA also actively worked on, and we currently offer installment plans for the overdue payments. And these installment plans can actually extend even beyond 3 years, depending on the beneficiary's ability to pay. Also, in terms of recommendations, another one was enhancing the registration process and the capacity of the administrative staff. And currently, we just launched actually our beneficiary management system, and it's currently in the piloting in Port Said, and it will be available for the entire governorates by next month. Also, in terms of establishing easy and accessible payment mechanisms with the launch of the BMS, there will be multiple integration with multiple payment portals to make it easy as much as possible for the informal workers to pay their contributions, as well as offering flexible payment plans, either quarterly or biannually or once a year. Another also recommendation was raising the awareness among the healthcare providers and the administrative staff about the services that are essentially covered by the Ministry of Health and are provided free of charge regardless of UHIS registration, because this was one of the findings that most people didn't actually know, that preventive services are covered by the Ministry of Health and do not require UHIA registration. And also improving service quality and conducting more comprehensive research to better quantify the issues and challenges, and to actually collect a bigger sample to make the results more robust. So this brings me to the end of my presentation. I'm sorry for taking a little bit additional time, but the floor is yours.
Well, thank you very much, Dr. Ahmed. That was really helpful to set the context for Egypt, especially the last point on the latest research that you've done in Port Said. Now I will move to very quickly to Dr. Sudarno, who's a honorary senior research fellow, and let me get to you, Dr. Sudarno, that you have done research on the JKN in Indonesia on the same topic of informal sector workers inclusion, where you supposedly have generated evidence to identify the barriers to enrollment and also to develop some policy solutions. So my question is twofold, basically. One, on the evidence generated in your research, on the JKN. And now, after hearing what Dr. Ahmed has mentioned and what Dr. Joe has mentioned, if you can, for example, highlight a couple of policy options that you think are still applicable for Egypt. And now the floor is yours, and we have like around 10 to 15 minutes, and so that afterwards we can hear from Dr. Mahlil as well.
Great. Thank
Thank you.
you, Dr. Ahmed Khalifa, for the great question. Good evening, good afternoon, good morning in Egypt. So I'm very grateful for the opportunity to share the knowledge that Indonesia has been, exploring for the last many years to achieve the universal health coverage, and also to share the state with such distinguished panelists. And thank you so much for the opportunity. And allow me to share the screen about what Indonesia has been doing in response to your question. All right, can you all see it?
Yes.
Okay, great. Thank you so much, Dr. Ahmed, again. So, thank you so much for the organizer, especially the JPL Southeast Asia and also the Egypt Impact Lab and also WHO in Egypt for the opportunity. And as in response to Dr. Ahmed Khalifa question about barriers, especially in Indonesia, that we have identified about almost a decade ago on this informal workers' participation in the national health insurance in Indonesia. I would like to, share with you what are the barriers of this informal sector participation in health insurance, and also how data help diagnose these challenges and shape the solution. And then this will probably highlight, and then I will highlight the most relevant evidence-based insight for Egypt, as you are now charging for your own path to go to the universal health insurance. So I will begin by setting the state about Indonesia today and Indonesia about a decade ago. So it started in 2014, where Indonesia made the monumental commitment to health equity by launching the national health insurance. I think Dr. Ahmed mentioned about JKN Mandiri, and the goal was universal health coverage for all. This is a bold commitment. And the number was staggering, as you can see from this slide, that as of 2025, nearly in the entire population, close to 99% of Indonesians are already covered. This almost 282 million people in Indonesia. Indonesia is the fourth largest country in the world after the United States. However, if you go back, this is it's a big achievement. If we went back the story, the success story had significant challenges from the beginning. In the year 2014, when we launched this one, about half of the population lacked formal insurance. A particular pain point was the non-poor informal workforce. This is relevant to, what the previous speaker mentioned, a group that makes up to about 30% of the Indonesian workers. And now it's actually growing this number, and they were and remain the hardest to reach. So what was the issue basically? To simply put, getting them to enroll and stay enrolled in the self-contributing National Health Insurance or JKN Mandiri scheme was extremely difficult. First, if you can see from the very left, low enrollment and retention, just 1 year in, only 20% of the target population had signed up. And the data also reveal a stark financial picture here, the second point here, that the average premium paid was less than half of the minimum required, showing a reluctance or inability to pay the full cost. Meanwhile, average medical costs were significantly higher, about 6.5 times of the premium collected. This indicates that those who did enroll were using service heavily. This combination created a perfect storm for the program's finances. We saw a clear sign of adverse selection here, where primarily the less healthy people enroll. compounded by year-round enrollment that allows people to sign up only when sick. And this poses a serious long-term threat to the system of financial sustainability. So given this situation, and then we discussed with the government at that time, with the Office of the Vice President and with the BPJS Kesehatan, who has been very, very supportive to us. So we work with, including Abhijit Banerjee, there's a Nobel laureate in 2019, Panel Rima and Amy, MIT, Harvard, and also Warwick colleague, to respond to the question from the government. The question was very simple, actually. Which barriers are holding back from the enrollment of the non-poor informal workers? They are not poor, they can afford, but they didn't buy insurance. What was going on here? So that was the question, was very simple. That was the basic of everything. And then we get together, we discuss with the national planning, Papanas, with definitely with the Ministry of Health and also BPJS Kesehatan with JPL Southeast Asia with the support from the US aid, DFAT at that time was the Australian aid, discuss about that question. And then we did this randomized control trial and tested the three potential solutions drawn from a simple economic theory. The first question was, does offering temporary premium subsidies increase enrollment and reduce adverse selection? This is in line with the previous speaker mentioned. And then that's the first question. The second one was, does simplifying the registration process by providing at-home assistance with online enrollment, lower transaction costs, and increase enrollment? Because it's very complicated, the procedure of enrolling, you have to have the whole family members enroll, and you have to have all of the identification card and everything. And the third one was, this is also relevant to the quest from the Egypt, thus providing targeted information on the financial risk of illness, the 2-week waiting period before coverage begin, and the legal requirement for insurance participation actually affect enrollment. For example, that we told them if you are not registering, and then we are not going to renew your ID or your driver license or things like that. And I was accused when I presented this paper in Tokyo that we were considered to be not ethical, but we are all in line with the request from the local government in Bandung, in one of the city in Indonesia. So that was the study then conducted in two big cities in Indonesia, in Medan and Kota Bandung. Medan is in Sumatra, Bandung is still in West Java, to capture cultural and institutional diversity while focusing on urban areas less affected by rural supply constraint. Uninsured households were randomly assigned to control group, full subsidy, or help subsidy, buy one, get one free, for example, group, with enrollment track for 8 weeks to assess participation in the JKN Mandiri. Beyond surveys, this is the good thing about Indonesia, we are allowed to get access to the very private data of the insurer. They allow us for 15 months to administrative data, track enrollment, payment, healthcare use, offering a clear, objective view of what actually worked. So these are the setting about the first question, Dr. Ahmed, about what we are doing, what were the questions, what were the barriers. So these are probably the finding, in the next 7 minutes. So I will be just using about 10 minutes in total, hopefully. So in a nutshell, I can tell that, this is probably the storyline that probably can be adapted or can be adjusted, the lesson learned from Indonesia, from the Egyptian. So in a nutshell, there are three things that I can say here. The first one is that affordability matters, but smart time-bound subsidies are key to inclusive and sustainability. So we'll tell you about what is the impact of subsidies, buy one, get one free, what is called the experience good in economics. The second one is on the reducing hassle. This is also similar to your country. Cost is essential. We don't want to burden people in the informal sector to spend much of his time, to travel much in terms of registration. And the third one is about information. Information campaign should be targeted and practical. Very simple, practical, targeted, not just having too many complicated things. Now let me dwell one of that point one by one. The first one is about subsidies. It turned out that subsidies help. Our first major finding confirmed an intuitive truth: price is a significant deterrent. When people had to pay for full premium, enrollment was low. Simply raising price to improve sustainability, a common instinct, turned out to be not working really well in this case. But we found that short-term subsidies are a powerful tool to get people to try to insure. They lower the initial barrier, allowing households to experience the system benefited firsthand. This is what so-called in economics the experience good, because they experience after participating, getting free, and then they will get to used to it. But there is the most critical insight for financial sustainability. Full subsidies didn't just increase enrollment, they actually expanded coverage at no additional net cost to the government. Break even. Why is that so? First, subsidy attracted and crucially retain healthier households. They stay in the system longer. We have the detail of the paper. Number two, in contrast, unsubsidized enrollees who had high medical costs early on were the most likely to drop out, creating a cycle of adverse selection. So by bringing a broader, healthier risk pool, subsidies can help program break even and become more financially sustainable over time. So full subsidy increased enrollment by about 19 percentage point. To be exact, is 18.6. This is equivalent to 116% compared to the baseline with no subsidy after 1 year. And then the second question is about administrative. Our second finding highlights less obvious but massive barriers. Administrative hassle. We discovered that out of the household that tried to enroll, only half were successful. The system itself was failing them actually. The biggest reported barriers were practical, like lacking the correct family card document, struggling with unreliable internet and complex website. This is not lack of demand, it is a failure of the enrollment infrastructure. This is something that we can also learn from Indonesia. And then when we provided a system registration, simple hand-on how to navigate the process, we saw a dramatic result, a 41% increase in successful enrollment. This proved that reducing hassle costs is just a matter as reducing financial costs. This is critically important, but 41% or 3.5 percentage point. And lastly, is about the importance of insurance. The question was, does information matters or does information affect household participation? Our third finding might be surprising. We tested providing different type of information about insurance program. The first simple one is standard detail about financial costs of having heart attack, for example, giving them a very scary picture, to the household. If you got sick and you didn't have insurance, you will sell everything you own, your cars, your land, and everything. And this is the story. This look very convincing, right? The second one is extra benefit. 40-day waiting period if you register, and then we'll give you the opportunity, the first payment or following day. And then the third one was the legal one. This is something that I was accused of being unethical. But this is again this request from the local government. If you are not having insurance, if you don't have health insurance, you are going to the office of the administrative office to renew your travel license. You are not allowed. You have to have insurance, things like that. This was just actually our hypothesis. What did we found? That none of the information treatment actually significantly increased enrollment, as you can see here from the standard and then mandated and then waiting period. They are all equally the same within the yellow and the dark one. They are not statistically significant. So this tells us that for this population, a lack of information was not the primary constraint. People decisions were driven more by cost and complexity than by lack of understanding. But this doesn't mean that campaigns are useless. They can be very low cost way to maintain awareness and reinforce right. But our evidence suggests that Egypt should not rely on information alone to move the needle on the enrollment. And the last one slide is that, so what happened when we combine the most effective intervention between financial subsidy and assisted registration? We can see here that we achieve a coverage rate of about 30% among this hard-to-reach group. This is a major increase from the baseline of 8% before our intervention. It shows that determined multi-pronged strategy can work. However, 30% also signal there is still large room for improvement. The journey to full inclusion is not complete, and for the achieve, the lessons are clear. You need to have these targeted subsidies, invest in simplifying enrollment, and then look beyond information campaign. And the final one that I would like to share with you is that by learning from Indonesia's evidence that Egypt can probably accelerate its own path of universal health coverage by avoiding cost trial and error and building a system that both inclusive and sustainable from the start, including the strengthening infrastructure. I think our colleague previously has already mentioned administrative structure and regulating price for the premium. And then for the future research, we can discuss later, but this is very much what I'm happy to share, and we have, presented to the government and, get attraction from them, and still a problem in terms of, our deficit. We can discuss about that, but in terms of the coverage, we are close to universal. With that, I will end my presentation, and again, thank you so much for the opportunity. Thank you.
Well, in fact, we would like to thank you, Dr. Sudarno, for this very useful and insightful presentation. I like how to generate evidence using scientifically sound methodologies. I always discuss with Dr. Reham how to utilize RCTs in our situation in Egypt. You gave us one very good example. And I don't want to, take much of the time, but really very much appreciate it. And also,
Yeah.
I'd like to acknowledge the good relationship between research community in Indonesia and also the government and policy implementation side. And you mentioned in the beginning of your presentation how BPJS collaborated with you on your research. So I'm very glad now to turn to Dr. Mahlil Ruby, who is the Director of Planning, Development, and Risk Management in the Health Social Security Administration, BPJS, in Indonesia. Dr. Mahlil, we're very, very pleased to have you with us. And we know that it has been, great from you to accommodate the webinar in your tight schedule. So we very much appreciate that. And now you're currently Director of Planning in one of the biggest health insurance in the world, if not the biggest in terms of population. And an issue like informal sector inclusion, if not dealt with properly in one of the largest insurance systems, it will make a huge impact, as mentioned during the webinar. So from a policy implementation point of view, we would like to ask you on, of course, again, we acknowledge the collaboration with the research community, but the strategies on the ground, how you uptake those evidence to implement it on the ground, and with the implementation, was it really successful? What were the challenges? And what do you look for the future to sustain this success in inclusion of informal sector population?
Okay. Thank you, Mr. Khalifa. Good morning and good afternoon in Indonesia, morning in the Egypt. Okay, my name is Mahlil Ruby. I'm the Director of Planning and Development. Okay, I would like to share with you about my experience or Indonesia experience in the informal worker enrollment under GKN. Yeah, next slide. Before that, I want to the disclaimer, my English is not perfect, and I hope you don't mind if my pronunciation is not perfect. So hope your translator is not confusing in my pronunciation. Okay. The key success of the and or national health insurance in Indonesia, we have the mandate the social security in our constitution. So based on this our constitution, we we launched or with the regulation we call of the National Social Security System, and we launched that in the 2004. And in 2011, we launched the law of the BPJS. Based on this regulation, we have the authority, or we have the power to increase the enrollment and increase the services. Next slide. Yeah. The reason, maybe my system the before to 2014 similar with the Egypt. The before we have the 5 different scheme. In for to the civil servant, that's time covered by the ASKES, and for the military by the Asabri, and for to the poor covered by the Ministry of Health, and for to informal covered by local government, and then for to private company covered by Jam Sostek. We have 5 scheme before, and then after 2014, we unified all the system in the one payer, and the payer for the health we call the BPJS Kesehatan to deliver of the health. And then in this single payer, we have the four type of the member, and we call the formal worker, and the poor and near poor, and the informal worker, and to non-wage worker. That is the type of the member in our next. And we can in this slide, I want to share with you. We have population now around 286 million, and covered now by JKN. The coverage is the meaning enrollment to BPJS. Have the 281 or 282 million, or 19.8%. Each member, we have the active and inactive. That is the problem, inactive to the letter. And the active, in the active, we have only the 81%, and the 18% is inactive. So inactive, we have 2 type of the member. The one member we call the formal civil servant, and then the private company. And the informal, have 3 type of informal in Indonesia. The first, poor and near poor, and the second is the local government enrollment, and the third is the voluntary enrollment, or Pak Sudarmanto said is the mandiri, the informal mandiri. So we calculate the contribution or premium based on percentage for to formal worker, and for to the informal worker, we rate the premium based on to the fixed premium. Fixed premium we related with the inpatient, the class of inpatient in hospital. If they choose the class 1, where in the class 1 each room consists 2 beds, and they will pay around to $9 per month and per member. In the class 2, for to the voluntary, they have to pay around to $9 per month per member, not per family, but per member. So in the poor and near poor and the local government, they have the premium around about the $2.5 and per month per member. And if they need the hospitalization, we provide class 3. Class 3 consists 4 until 6 bed per room. Meanwhile, for the formal, we rate the premium based on percentage to payroll or to income, 5%, 1% employee, and 4% to employer. That is to non-subsidized premium. Next. Yeah. Based on your question, what the effective strategies to increase informal worker enrollment in the GKN program? Based on my experience or my experience in the BPJS, the first strategy, under the National Social Security System law, the government is mandated to provide coverage that is based on the law. In the law, mandated to central government to cover the poor and near poor. Next, the second strategy, we like the Dr. Ju said, we develop partnership with local government. The role of the local government is very effective to increase the enrollment, the informal worker. Which type of this member for the local government? The type is the poor and near poor in the economic decile. The 1 until 4 decile, 4 to the poor near poor, where this member covered by the national government. Above that, for 5 to 7 decile will covered by local government, or maybe mistarget national government will covered by local government. So the local government, maybe almost all the local government, when the campaigns, they bring the JKN as their politic campaigns. So that is one of the opportunity to us. So almost all the candidate in the head of the district, head of the or the governor, they bring the issue JKN as their politic offer to their campaign. And then several government, our staff only conduct the synchronize of the data at policy, and then coordination with their office responsible for their budget or their health. And this is our role in increase the role of the local government to enrollment the formal worker. Next. And the third strategy, we simplify the enrollment and the payment and expanding channel. We develop the auto debit with all the bank in the Indonesia, including the private bank like the BCA and the Syariah bank. That is, they can pay the something with the pay through the government bank or the private bank. And then we develop the auto debit, and we cooperate with the many payment channel like the mini market or the other like the post office, and then the another side cooperation. Until now, we have more than 1 million channel to payment premium by the informal worker. And we have to the digital platform. where the digital platform we call the JKN Mobile, and we have also Pandawa, the one of the digital platform through WhatsApp, and every member they can to send something about their member premium, their health services through WhatsApp. Next. And the fourth strategy, how we can to build the trust to our informal worker, because they easy to in out. If they trust to our program, especially if they're sick, ill, when they utilize hospital, they will get to something satisfied. So we improve to them how we can and the broader access to health services. So until now we have more than 25,000 primary health facility, and more than 3,100 hospital we contracted now to improve the access to our member. And then we define the hospital quiz system, online referral. So if the member want to using or utilize hospital, for example, they can to quiz from with the online. Okay, I will come at 10 o'clock. Okay, because this is my time to services by the doctor. And then each hospital or the primary health facility, we conducted credentialing to make sure the quality in health facility. And in health facility, we developed something a charter, and each health facility has to conduct their services like their charter. For example, uh, they don't take the out of pocket or the add something in the member get services in your hospital and in your primary health services. And then in the hospital we put our staff to handling the direct to handling for example the complaint about their eligibility the member, or complaint about another services, we put something our somebody in the hospital. Is the fourth strategy. And the fifth strategy is based on our law. In this law, National Social Security System, in one article, to increase activity of active member of the informal worker, because informal worker we don't take premium automatic. So we need their voluntary to pay direct to bank, to account. So if they don't pay, they don't active. So we maintain our retention of their active membership. So we in this law to put the sanction we call the public service sanction. What the meaning public service sanction? The public service sanction is everybody come to the public service like to police or to their license or education, immigration. If they don't active the membership, they have to fulfill the active membership. After active, they can get that public services. And then in the 2020 to 2022, we get to the new regulation from the president. We call the prudential instruction. where this instruction, the president instructs all the ministry and all the institution for to implement this public service sanction. And then we need something for to conduct the public service sanction. We have to strengthen data and interoperability among the ministry or the other stakeholder. And so if they come to the stakeholder, they can look, okay, you active or not active your membership. And lastly, the next. Yeah, we enhancing targeting through the data integration. We have two body BPJS, in the one BPJS in health, in the other BPJS in the employment, and we interoperability or integration our data with BPJS employment, and then we integration with the Ministry of Social Affairs, because the Ministry of Social Affairs is the ministry responsible for the poor and near poor data. And then now the National Single Social and Economic Data of the DT That is the data is we can get information everybody or every family what decile their position now. So based on this data set, the Ministry of the Social Affairs, they will cut the poor and near poor. If they don't is not poor again, they will exclude, and maybe we can fill the other people with the poor status. Next. And next, what the policy innovations and reform to strengthen the coverage and the sustainability for the informal sector. This is based on our experience. That is like the Mr. Khalifa said. Yeah, we have the many challenging in the implementing the informal sector. You and Pak Sudarno is said it maybe that is the very difficult to enroll into the main or to maintain the active of the informal worker. The first challenging is informal worker, affordability and income irregularity. They don't have the income, the stable income. That maybe this today they good income, maybe the next day they don't have the income, and so based on that, to make the many challenge or to difficult to active for this worker. And then moral hazard. So we call with adverse selection, joining when and dropping out when when health or when well, and this is the moral hazard. And then ship value and trust gap. They forget the date of the premium payment and the negative experience, because the last month they utilize hospital, but is services is not good. That is negative experience. So based on that, they don't want to continue payment the premium payment, and lack of understanding. So until now they still think so they will active if they sick. And then short-sighted. Okay, I don't know, because I'm younger and I don't sick. Why I join or why pay the premium? That is the perceived value and the trust gap in this worker. And then the another is politics and fiscal capacity. This year, all our district or the local government have cut the budget from the by the national government. So the local government until now to have the limited the capacity fiscal capacity. And the data validity, we still struggle with the debt. If the somebody dead, we don't know information they dead, and this debt they don't inform to administrative office citizen. And then newborn is as well, and identity duplication is the another problem. And lastly, the challenging is the our call the technology aspect, like the lost number contact, and we cannot access to COM, or low digital literacy, or low access to the internet, and then the uneven digital utilization. Our challenging, and based on this challenging, we develop some innovation or policy. Next. Yes. A policy innovation and reform to strengthen informal sector. The policy, and we our government this year, they have planned to write off and learn arrears through president regulation, maybe last year or the early next year. And we regulation or policy the waiting period, and then we uh, we uh, we implement the policy we call the implementation of 45-day service penalty period. If they use if they inactive, and if they want to active when this day active, and this day they use the health facility, especially hospital, they will there will penalty around the 5% to claim hospital. We online taxi drivers, maybe this year the president will make the president regulation, the online the applicator will take cover the driver, and the driver will pay or his family self. And then to policy clearance certificate, that is a young active and membership is requirement for the policy certificate, and in immigration, and then the social security curriculum. And now we put this curriculum for to junior high school and to the senior high school. So hopefully this curriculum will increase their knowledge about the value of the social security. And we have the innovation, maybe almost 10 innovation. We call the rehab is the pay off the errors, and the outbound call, and data validation, and village enrollment of information, and then contribution sharing scheme with the corporate or with the religious fund, and then integrated enrollment and reactivation object for Haji pilgrim, and then tracking for lost contact. If contact the telephone, the number of telephone is lost, we can get through another tracking. And then you will receive citizenship administration and JKN membership during birth, and then JKN cadre to collection of error premium and daily collecting. That is our innovation to increase retention of the membership of the informal work. And to the next, we will implement the adaptive contribution, like to out to the bird, a wallet, retail agent, and we can to flexibility payment weekly or daily. And then due to the membership is the over the capacity, or we can call the catastrophic, because the premium is the fixed amount and not per percentage by their income. So maybe to the latter, we know is design how to in proportionate premium, for example, 5% to their income. That is we have to challenge how to rate their income. Maybe that is our hypothesis. Maybe we can rate through electricity, and then to their ownership of the car, and another their saving in the bank, or they have to pay the tax through the Ministry of Finance. Maybe that is the we can to rate the proxy of their income. And then we will to involve the another institution, because if the automatic payment, and if we voluntary, that is very vulnerable. They don't continue payment. So we will coordination, or we will involve with the cooperative, and then with the religion like Muhammadiyah, and then to micro enterprise, we can collect this premium, and we will sing with local government with the micro enterprise. I think that is the policy and innovation and reform to increase or in strengthening informal sector. Thank you. Back to your Khalifa.
Well, thank you very much, Dr. Mahlil, for this. I've seen a lot of similarities between, in terms of design, between the system of Indonesia and the system of Egypt. But also, I took note of the 6 strategies you mentioned, and also the policy innovation you have highlighted in the end, which were very, very useful in our case. Now we already are 15 minutes beyond the webinar time, allocated time. So, which means that it was very dense and helpful. I didn't want to cut any of the presenter because of the very rich insights that you were all saying. So the plan was to have a couple of questions and then final reflections from our speakers. But in this case, I would just maybe kindly ask all speakers if they can, because somebody asked on the materials. So if the materials can be shared, that would be great, and then we can share it with the whole group. And from my point of view, I've seen a lot of common themes across all speakers, and particularly when it comes to solutions, like 5 or 6 main strategies are. There's an agreement across all speakers about like the subsidies, the administrative smoothing, and also the information campaigns, the point of digital transformation, and the role of local governments and central governments. So all are possible solutions, but it differs with the extent of its effectiveness on the ground. So that's from my side. I will leave the floor to each of the speakers to just give final reflection before we close. So this time I will start with you, Dr. Mahlil, if you have any final thought or conclusion to give to the audience, and then I will give the floor in order to Dr. Sudarno, Dr. Ahmed, and Joe, and then we close. So if you have, Dr. Mahlil, any further remarks, that would be great. If not, your presentation was already
Okay,
very,
yeah.
yeah.
Yeah, please. No, I don't have
Yeah, sure, sure. Dr. Sudarno, do you have any final reflections?
Yes, definitely. Thank you so much uh, for the opportunity, and also Dr. Mahlil for your kind and generous giving access to the team. I think this study that Indonesia did is very unique in terms of giving access to the administrative data, linking administrative data with the survey data. So I think Egypt can also do the same if we have that, so we can see about the dynamics, about the behavior of, of these people working in the informal sector. Again, this is the most difficult undertaking. We talked with Abhijit Banerjee about having bundling. This is insurance, but there is also like investment type. And that's something that we need to explore in the future. So I think in terms of for IGP, actually the path forward is involving using, smart subsidies to increase the enrollment. I think the idea about this experience good is something new. In the past, people doesn't care, but after they got hit, with all of the shock, and then they realized how expensive it is, and then they will purchase this insurance. This I would like to emphasize in terms of the reflection in terms of this experience good, and subsidies matters a lot. I think Dr. Mahlil already mentioned about Indonesia has been very generous, but now we are also having sustainability issue because in the past, like Dr. Mahdi mentioned, part of this informal sector PPI was paid by central government, and there is also contribution from the local government. But now we have a budget cut from central to local. This is all going to create a sustainability issue. So I think the on reflection is, Dr. Awal, is about how can we maintain this balance between sustainability and also participate inclusivity. And we need the smart policies, and there are still issues that we cannot resolve during this seminar, but I think this is a great opportunity for one of all of us to learn from each other. So I think that's my again of having the dynamic and also the behavior of our participant in the health insurance in the informal sector, especially how complicated it is. Yeah. Thank you.
Thank you very much, Dr. Sudarno. Dr. Ahmed, would you like to give some reflections to conclude?
Thank you, Ahmed, and thanks for all the distinguished speakers. I really enjoyed the three presentations, and I already got a lot of ideas flashing through my head while listening to the presentations. So I think it was actually a very, very insightful presentation. Of course, we all know that informal sector enrollment is one of the key issues facing all contributory schemes worldwide, and it's an ongoing process to deliberately create incentives and try to facilitate the enrollment of these people. So thank you all for sharing your experiences and your insights. And I think a lot of these insights can actually be implemented within the Egyptian context. And I got a lot of ideas from these presentations. So thank you for your collaboration, and looking forward for future events, inshallah. Thank you.
Thank you very much. Dr. Joe, please.
Thanks. Very interesting session. I really want to thank our Indonesian colleagues for sharing that experience and really the research. I think what came to mind from this, which is important, I think, as Egypt tries to adapt and take things forward, is the level of political commitment that it takes so that basically, having people affiliated to the program as a high political priority, and then ensuring that, as we saw in Indonesia, you have this quite comprehensive approach is critical. And it's a challenge to sustain that, not just financially, but also politically, right? So I think this is something to recognize. I think the critical role of research, that research was given in the process, is important. Because I think one of the important messages is that, this is a very difficult approach to ensuring affiliation for health coverage. In a way, kind of non-contributory approaches are much simpler in many ways. But not every country goes that route or can go that route. So one point which is key is that this is not a problem you ever fully resolve, right? So it's going to take ongoing work and having institutes that really give a place to applied research to continue adapting, continue kind of trying to shrink the problem and then deal with the things that, nobody thought of today in a sense that might be unique to your context is important. So I think there's a lot to gain from the experience we heard today, and it'd be great to see that material. And I think it'll be of value to a lot of countries, but Egypt in particular, that's going this contributory route. Thanks.
One more, Dr. Ahmed, just one more. So,
Yeah.
Dr. Chu, thank you so much. I forgot to appreciate when you said the state about the informality, the definition, and everything. That's great. And yes, so feel free to use the material that I had, and we have the paper. I'm happy to share with you. It's published in, I believe, in the American Economic Review with Abhijit Banerjee, and we are still thinking about doing something more in the future. Thank you so much. Appreciate it, Dr. Chu. It was great.
Well, thank you. Thank you very much. We will also try to disseminate the research to all the group participants in the group as well. Dr. Reham, would you like to say something in the end?
Thank you very much for all our guest speakers for the insightful topic. Actually, it was really very important. But actually, I cannot end it. I don't have any reflection rather than I do have like a bunch of questions for the audience. I won't be
We should
able
have
to close it.
plans
Just
for
two questions.
sessions.
Two questions. So just two questions, because this is really very insightful, and I mean, the Egyptian side actually can learn a lot. My first question to Sudarno, very briefly, you highlight the criteria, the specific criteria that you use to differentiate between those who are subsidized informal and those who are self-contributing informal workers, and how you can handle the gray area between them, the near poor who actually are not qualified for being subsidized but also cannot afford the premium. Also, another question to Dr. Mahlil related to the policy innovation that you have just mentioned about the VHAP phasing areas payment schemes. Actually, I really want to know more about what the design features that make it more effective, that can make it more effective than the original one in the study that has been conducted. And also when it comes to the different premiums rates, and this question could be for both Sudarno and Mahlil, how Indonesia actually offer, and what are the enforcement mechanisms that can make us actually design different premiums and still succeeded in collecting them? That's all. Thank you very much. And I want to ask more.
Those are all great questions. I will let Dr. Mahlil Ruby to respond on the detail. But let me, sorry, on your question regarding my presentation, how and the gray area about who should be subsidized, which and things like that. On the subsidies, like Dr. Mahlil mentioned, Indonesia is very advanced in terms of targeting system. Now we have this national targeting social registry that cover almost 98%. So we know about those belong to the bottom 40%. So the bottom 40% are basically covered by government contribution, no tax. But above that, between 41st percentile to 60th percentile are actually those working in the informal sector who are not poor, but they don't have insurance. They don't want to buy insurance. So I think that's the way how the study is, handling the issue about the informality and also buy one get one free. So we start by doing all of this survey who belong to this group and that group. I think that's the way how we identified Dr. Reham, if I understood correctly your question. And then Pak Mahlil probably can respond about your innovation, Pak. 11 innovation that, you're working on it.
Yeah. Thank you, Mr. Reham. Okay. I I get your question about the how to my the calculate the premium. Yeah, premium we calculate based on the actuarial approach, and actuarial approach uh, we divide among among the type of the membership the especially for to uh, 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 formal worker like the subsidized, we call the experience premium based on the last year premium. This premium will increase the cost. So to the government, we will request the new premium or the new subsidized for to the government subsidized. And the collection for to the government, the collection only government will allocate to Ministry of Health, and Ministry of Health will pay to us based on by name and by address to the people. Okay, if you do you have the name 60 million, okay, I will pay to you amount something trillion rupiah. And for to another not subsidized for the forestry, that is very difficult to collection them because the member is the member active, the member on they have something the high risk, especially the active is the old people, and then they have the chronic disease. That is the active member in the our membership. So they if they need something, they need to use health facility, they will pay regularly the premium. That is we call the, yeah, maybe that is adverse selection for the national level, but we don't to make this adverse selection by segmentation of the membership, but that is the responsible of the government. The adverse selection is the one of the risk if we want to implement the national health insurance. The national health insurance, we cannot use of our theory of the adverse selection. The adverse selection is very powerful to the commercial health insurance. That is our government. Okay, if you need something, increase your premium, please request and give us to your data and who utilize this health facility. And this year, maybe the last year, the government will take the new premium to the next year. Maybe the next year government will increase the government subsidize. Uh, I hope my answer can answer my response can answer your question.
Well, thank you
Definitely.
very much. Yeah, thank you very much to all our distinguished panelists, and thanks to all participants for staying for the whole session. Can't thank you enough. Just an announcement. Our next webinar would be on contracting primary healthcare units and centers, and this will be in 2 months' time. And in this next webinar, we will share experience from Thailand. So thank you again, and thanks for the Indonesian experience, and hope to see you later. Thank you.
Okay. Thank you, Dr. Ahmed. Thank you so
Thank you.
much. Thank you,
Thank you so
everyone.
much. Thank you. See you
Thank
later.
you.
Thank you, Baba
Thank you
Mahir.
all.
Bye. Bye.
Bye-bye.